Hello and welcome to the COMLEX Instant Review. Let's talk about leukemias. Best way to make the diagnosis of leukemia is by age. So if the board exam question tells you that the patient is above 60 years old, think about CLL. If it's less than 15, you're thinking about ALL. ALL will commonly present with lymphoblasts, and acute leukemias are conditions where blasts predominate. Children or elderly typically have acute leukemias, and short and drastic course is characteristic. With AML, you'll see myeloblasts, and the median age of onset is around 60 years old. CML will have patients who have myeloid stem cells, such as the blast crisis, and patients who have CML typically age between 30 to 60 years of age. Keep in mind, with CML you have the BCR ABL hybrid gene and the translocation at T,9,22 Philadelphia chromosome. So that's a common association that you should remember for CML. It's defined by the Philadelphia chromosome. There is myeloid stem cell proliferation that presents with an increase in neutrophils, metamyelocytes, basophils, and also splenomegaly. It may accelerate and transform to AML or ALL with a blast crisis. There's very low leukocyte alkaline phosphatase levels, and it responds to imatinib, which is an anti-BCR-ABL antibody. So those are some of the key points for chronic myelogenous leukemia. Again, the age is going to be really useful. It's between 30 and 60 years of age, where CLL is found greater than 60 years of age. Another important point about the leukemoid reaction is that an increase is seen in the WBC count with a left shift with approximately 80% bands, and an increase in leukocyte alkaline phosphatase levels. So that's considered to be a leukemoid reaction, whereas in CML you have a very low leukocyte alkaline phosphatase level. With AML, patients typically present with Auer rods, increase in myeloblasts on proliferal smear, and M3 that responds to all trans-retinoic acid, causing vitamin A and inducing differentiation of myeloblasts. With CML, as we mentioned, you have the Philadelphia chromosome with myeloid stem cell proliferation but an increase in neutrophils. So the cell types vary across the different types of myeloid neoplasms. Again, with AML, characteristically look for the Auer rods and M3 type that responds to the all-trans-retinoic acid, vitamin A. Those two are the key points for AML and for CML. Now let's talk about ALL, acute lymphoblastic leukemia. Here patients will have usually a TDT positive, that's a marker for pre-T and pre-B cells, CALA positive signs, and with bone marrow involvement in childhood or mediastinal mass in adolescent males. It can spread to the CNS and testes, and a T12,21 usually indicates a better prognosis. Now what about small lymphocytic lymphoma, SLL, or chronic lymphocytic leukemia, CLL? Well, these patients often are asymptomatic. They have smudge cells in the peripheral smear, warm antibody, autoimmune hemolytic anemia, and the SLL is the same as CLL, except CLL has an increase in peripheral blood lymphocytosis. So with CLL, you want to look for the increase in the lymphocytosis, whereas with SLL, there are still smudge cells, but it's going to have less amount of the peripheral blood lymphocytosis. Also, hairy cell leukemia is seen in the elderly, where patients stain with TRAP, tartrate-resistant acid phosphatase positive stain, and here mature B cell tumors are seen in the elderly, and cells have a characteristic filamentous hair-like projection. With all these leukemias, there's going to be an increase or decrease in circulating leukocytes, and anemia causing a decrease in RBCs, decrease in mature WBCs, and some sort of a hemorrhage. So RBCs, WBCs, and platelets will be low. Patients will typically have infiltrates in the liver, spleen, and lymph nodes. And so those are some of the key characteristics that you want to look for in patients who present with leukemias. Again, our rods are peroxidase positive cytoplasmic inclusions in granulocytes and myeloblasts that are commonly seen in acute promyelocytic leukemia M3, and the treatment of AML M3 can release our rods, leading to DIC. So those were some of the high yield points for the leukemias for the board exam that you may want to focus on. In addition, let's talk about Langerhans cell histiocytosis, also known as histiocytosis X. Here patients have proliferative disorders of dendritic cells from monocytic lineage. So there's defective cells that express S100 and CD1A cells, and Burbick granules, that's a characteristic sign. Tennis rackets on EM are characteristic. And keep in mind that patients will have Latour-Save disease or Hand-Schwaller-Christian disease with eosinophilic granulomas as the characteristic signs. In addition, patients who have histiocytosis X will have cells that express S100 and CD1A positive markers. Now, some of the chromosomal translocations that are seen can help you narrow down your differential. For example, T11,14 is seen in mantle cell lymphoma, T11,22 is seen in Ewing sarcoma, T15,17 is seen in M3 type of AML that's responsive to the all-trans-retinoic acid, and T14,18 is follicular lymphomas with BCL2 activation. So here, patients have T11,14, think about the mantle cell lymphoma. 11,22, think about Ewing sarcoma. 15,17, think about M3 type of AML. And 14,18, think about BCL2 activation. And T,922, Philadelphia chromosome with BCR-ABL hybrid CML chromosomes. And that was a board review for the COMLEX and USMLE exams for some of the key leukemias and chromosomal abnormalities that you may see, and markers for hematology and oncology. Please visit COMLEXflashcards.com at www.comlexflashcards.com for additional board review lectures, and good luck in your preparation for the boards.